It's a couple of minutes past. Will we make a start? Yeah. Okay. So welcome everybody to our education session tonight. I'm Jo Silver. I'm the GP advisor at Western Health, and tonight we have Yvonne from the PHN with us, and Dr. Mandy Huramath and Dr. Trupti Prasad, who are our paediatricians, who are presenting for our session on ADHD. So I'd like to begin the session with our acknowledgement of country. Northwest Melbourne Primary Health Network and Western Health would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just a little bit of housekeeping for everybody who's joined. We have everybody on mute, and if you could just ask questions through the Q&A box. Don't use the chat box for questions because we can't move things across. Then we'll be able to sort of monitor and get answer questions as they, most of them will hold till the end of the session, but if there's something pressing, will pop up and interrupt the presenters. Just if you could make sure that you your name is showing as the name that you've registered with. If you're having trouble changing it over for whatever reason, if you could just put a comment in the chat box for Yvonne to tell her who you are and your RACGP or ACRON number, so as she can ensure that you get your points and your certificate. Thanks, Yvonne. I'm just going to give you a little bit of an outline of the health pathways. There is a new health pathway on ADHD, which is really helpful for GPs to be able to have a look at. So most of you are aware of health pathways. If you're not, then I'd really encourage you to get yourself registered so as you've got access. So the pathways have been written by GP clinical editors, so they're all GPs, and they've had support from other local GPs, hospital-based specialists and other subject matter experts. And they're really detailed and easy to use. So like I said, there is a relatively new pathway on ADHD in children and youth with related mental health pathways that you can link through to. So the pathways are all laid out in a consistent format. So you'll get some information about the background information about the topic that you're looking at. So easy to read, gives you the concise information to be able to start to work through assisting the patient if you're not sure about the topic and where to go to work through it. It's got some information on assessment. So we all know that you cannot sort these problems out in, 10 to 15 minute appointment. So you're going to have to step yourself through working this out and getting them back for a couple of visits to start to gather some information and explore what's going on. So it gives you some advice on what to look at in the initial assessment, and then how to gather that information in longer appointments, and also some resources that you can use to help you gather that information. So some of the, and additional resources and referrals that you can make. Slide. So some initial management guidelines, and where you can get that extra information, because as GPs, we're not going to be able to, people might come in with that expectation that I'm going to need some medication. And that's only one part potentially of what needs to be done, but there's a whole lot of other things that as GPs we can be getting parents and families to work through. So, and then the management and additional resources. So places where you can go to get reliable information for parents, and also how to have that discussion with school teachers, because often it's going to be, you're going to need to gather some information from what's happening in the classroom as well. So there's how to, if you're not registered with Health Pathways, you can go on to Melbourne Health Pathways and apply to be registered, and the PHN will come back to you with the access codes. All right. So like I said, we have two fantastic speakers tonight, and they have presented previously on ASD. So Trupti Prasad is one of our paediatricians at Western and also works up at Bacchus Marsh, and she's done her training in Melbourne, and she has special interests in trauma, autism, child behaviour and development, and is involved in a range of clinical services, clinics in Western Health. So that's Trupti. And then Dr. Mandira Hiramath is another one of our paediatricians who's trained locally and works in the West. So it's Sunshine and up at Bacchus Marsh. And she has an interest in multidisciplinary autism assessments from preschool to teenage years, pathway. She also works in Pathway to Good Health Clinic, neonatal services, and assessment of a variety of developmental paediatric problems. So I will hand over now to Mandy and Trupti. Thank you.
Thanks so much, Jo, for that introduction, and I hope everyone can hear me okay. So as Jo introduced, Dr. Trupti and myself will present a short presentation on ADHD, and then after this we will leave some time for some questions and answers so that you'll be able to just clarify anything that we've spoken about or anything that's outlined in the Health Pathways information that you've been wondering about. Just checking my way. Yep. So before we go into the main content of the presentation, these are the two sites that me and Trupti primarily work at. So on the top left-hand corner is Melton Health, and this is where we do most of our multidisciplinary clinics from. We've got developmental and behavioural clinics and medical clinics as well. On this site, we have eight paediatricians in our team, as well as training doctors, including fellows, registrars, and HMOs. So we're a training site, not only for the medical professionals, but for allied health as well. On the bottom right, we've got our site at Bacchus Marsh, and the clinics are primarily run through 10 Turner Street. And here we not only do the developmental and behavioural paediatrics, but we also have neonatal services as well. So in this presentation, as discussed, we will be focusing on ADHD. But before we go into that, we'll briefly discuss about neurodiversity and how ADHD fits under that label. What does ADHD look like, and what are the common presentations or examples that you may see? And then I'll hand over to Trupti for a discussion about the diagnosis and management of ADHD and the role of paediatricians and GPs in that process. So what is neurodiversity? So neurodiversity essentially is a term to describe the neurobehavioural differences in our population. It essentially includes all these terms, and I'm sorry, it is a busy slide, so you don't have to read all the specific text, but this just gives an example of various terms that may come under that larger label, that larger umbrella term. And as you can see, ADHD is just one of those terms. So these children and adults who do identify as being neurodiverse will feel that their brains function in a different way to others, affecting the way that they see, process, and think about the world around them. This gives them a number of strengths and can often lead to their success and improve functioning, but obviously because it is different, it does bring about the challenges as well, and each of these sub-labels have those different strengths and challenges associated with it. So these myths and misconceptions are presented because these are often things that families come to us with. And unfortunately, these myths and misconceptions, they can be either anecdotal from experience from other family members or friends. And unfortunately, these labels can often delay the diagnosis or even slow down supports, people and families accessing supports for their children. So going through these one by one. So often when families present to us, they're brought in with a kid that they label as being naughty. So this could have been by a school teacher, an educational support, or their family members. Often these families are told that they need to put firmer boundaries in place, and that could be related to sitting and concentrating on work or homework, or they could need to be sitting and focusing at meal times, or trying to get them to sleep is difficult. Another misconception is that it's all because of the sugar and dietary. So again, lots of families coming to us saying, oh, I've tried to cut out all the red food colouring or all the sugar in the diet and it's not helping. What do we do? The next one is that only boys have ADHD, and this is definitely not true, and we'll go into this a little bit later, but it tends to be with the differences in the ADHD presentations that do occur in society, but also the more subtle features that girls often present with, leading to girls often being undiagnosed with ADHD. The next one is that children with ADHD will outgrow it. So what is the point of management? We know that ADHD presents differently in our children and young people compared to adults. In children, it may present as the hyperactivity, the difficulty sitting still and paying attention. As this evolves through the lifetime in young people, this may present as mood changes, as difficulty with education, and then leading to adults where poorly treated or poorly managed ADHD can often result in issues such as substance abuse, incarceration, relationship breakdowns, and also employment challenges as well. So just relating it to children outgrowing it, I don't think that's as supportive as we can be for our community. The final thing that families often come to us saying is that, oh, my child can't possibly have ADHD because they can focus on TV and they can sit and watch their favorite TV show for hours, or they can sit and do, a Lego blocks for hours, particularly about their own interest. They can't have ADHD, but part of ADHD is that difficulty concentrating and focusing on tasks needed for daily function, not just something that's own interest focused. And again, we will discuss this briefly later on in the presentation. So what are the statistics of ADHD in Australia? So these statistics are constantly changing, and that's because knowledge and awareness of ADHD is constantly growing, and there are other pressures. And I guess one of those key pressures is COVID, which made the awareness of ADHD to families raise that awareness, because families were then forced to homeschool their children and saw these educational challenges in the home environment. But the most recent statistics show us that 1 in 20 Australians have ADHD. ADHD is the most prevalent mental health disorder affecting children in Australia. More than 3/4 of children continue to experience symptoms into adulthood, but as I said, these symptoms may change and evolve with time. And ADHD is more common in boys, but as mentioned before as well, was that girls are often undiagnosed, and that's due to their subtleties in their presentation. So what are the causes of ADHD? We do know that there is a strong inherited component of ADHD. So if you do have a family member with ADHD, there is a likely chance that subsequent generations may also have ADHD as well. But we also do know that there is no one single cause for ADHD, and there are multiple contributing factors as well. So in addition to genetics, there may be pregnancy exposures such as alcohol, drugs and tobacco use, exposure to environmental substances during pregnancy or at a young age, premature delivery, low birth weight, and brain injuries as well. When we diagnose ADHD, we tend to follow the DSM-5 criteria, and the DSM-5 criteria split ADHD into 3 categories. So you've got the predominantly hyperactive, predominantly inattentive, and then your mixed type. And these these presentations have to go across at least 2 settings, for example, home and school, and need to be present for at least 6 months. With the inattentive subtype, this is often presents to us as the young girl who at school is always daydreaming, struggling to pay attention, not completing work, but again, as I said, can often go unnoticed in the classroom. So this includes 6 of the following, or 5 for people over 17 years of age, and that includes lack of attention to detail, frequent mistakes, daydreaming or drifting off in class, getting distracted, starting things and not finishing them. And then what's sort of noticed in those older age groups is the disorganization, that procrastination. So when those pressures of high school and employment increase, you can notice these sort of features, losing things, and then, as I said, poor at adulting. So just really struggling to stay on top of basic things like, finances, taxes, meeting deadlines, and all of those sort of things. And then you've got the hyperactive or impulsive type subtype. These are more commonly the boys, but it can occur in girls. And these are the boys that the parents often come in to describe them as if they're running on a motor and they're always on the go. They struggle to stay seated when it is expected. For example, in the classroom, at a meal table, they're often running around, climbing on tables. They are quite impulsive in that they will frequently interrupt. They talk a lot, and they have difficulty waiting their turn. And it's these impulsive kind of behaviours that then cause difficulties in adulthood, because essentially there's the planning and forethought may be not as ideal. And then, as I said, you've got the mixed subtype, which is a combination of the two. But as I alluded to earlier in the presentation, there are a number of strengths of ADHD that we need to consider, and by identifying these strengths and using that to the advantage of the young person or person that we're trying to treat, we can empower that young person and treat it more as a understanding rather than a diagnosis or a disease. And so these are some of the strengths. So at the tip of the iceberg, people have this misconception that, people with ADHD are good at doing things really fast and creativity, but there's a lot more than that. They're often quite optimistic, they're competitive, they like accepting challenges. There is a thing called hyperfocus, and that's what I was discussing before, in that they can have quite an intense interest, and often can focus and put everything into that, and because of that can often go misdiagnosed. They're quite entrepreneurial, and they're good at problem solving. So these are some of the strengths, and as I said, it's good to identify these early so that can be planned into the support strategies that we use as well. So as discussed before, with neurodiversity, it is actually not very common that there is only one condition at a time. And as you can see from this slide, when we look at ADHD as one of those terms under neurodiversity, ADHD alone only really happens for 30%, which is a relatively small amount. Other common comorbidities include other learning difficulties such as dyslexia and dyscalculia, autism spectrum disorder, mental health issues such as anxiety, depression, and other things such as tic disorders as well. So when we diagnose ADHD, obviously we'd like to identify that early, but we also need to keep our minds open for other comorbidities so that these can be supported, and the person can be helped with these sort of things as well. So I'll hand over to Trupti now for the diagnosis.
All right. Thank you so much, Mandy. Can everyone hear me? Great. All right. Thanks very much for that, Mandy. So I'll continue on. So it seems like it's complex to diagnose ADHD, but certainly one of the biggest things it needs is time and information. And we do know that that's something that can be a little bit lacking in the land of the general practitioner, due to the nature of, your setups in clinics. But we'll give you a bit of an overview on our approach. So the diagnosis comes from really the comprehensive developmental history in examination, including gathering collateral history from schools or kinders or other settings that the child might attend, as the behaviours really need to be present across more than at least 2 settings to be considered problematic. So some of these questionnaires, like the one that I've put on the screen, you could actually give to families to fill in and score. They're very simple. They're based on the DSM-5 diagnostic criteria, and you can use it as a bit of an indication as to whether ADHD might be a diagnosis that you're suspicious of. That's a really easy one to Google. It's called the SNAP-4 questionnaire, and I'm happy to distribute it after the webinar with some other resources. It's also important to look at other things such as routine, parenting strategies, sleep, and the whole family dynamic, as these factors can greatly impact on symptoms. So an overtired, screen-addicted child is certainly going to be more dysregulated and have more prominent features of ADHD than they would otherwise. It's also important, as Mandy mentioned, to consider the other differential diagnoses. And so sometimes I find that a really quick screener is to chat directly with the child, as I'm sure you all do. Ask them about what they like, what they dislike, what they're interested in, who their friends are, whether they're able to name them. And just these really brief introductory questions can give you a bit of an understanding into their speech and language abilities and their cognition. And then if you get the kind of kid who just rambles on about something quite tangentially, then you can start to wonder whether there's some other things going on for them. Here's some examples of some other screening questionnaires we use. So the 2 up the top are the ACEBA Child Behaviour Checklist and Teacher Report forms that our service use. There's also the Vanderbilt assessment scale that is used quite widely, because that one is free to print and score, whereas some of the others, including the ones that I've mentioned, plus the Connors that are maybe more targeted at ADHD symptoms, are ones that you have to order and pay for. And obviously, as I mentioned, the SNAP-4 is free as well, which is a really good screener and probably very manageable even to complete within a shorter consult. Once the diagnosis is made and we've gotten information from the developmental history, from collateral information from school and other settings, and spoken to the family at length, the decision really then comes down to what do you do with that diagnosis? And that really comes down to functional impairment. And much like anything that we do, you're really trying to work out what influence is this having on this child's life at this time, and in the family as well. Some of the families that we have in the Melton region are very complex, and so your threshold to treat might be lower than they might in some other families, because the children are a function of their family situation as well. There are some children who are quite bright and cognitively able, who will be able to mask their symptoms better and use other supportive coping strategies, or who are very well scaffolded at home and who can manage quite well with non-pharmacological strategies. The risk of underdiagnosis or non-treatment, as Mandy mentioned before, relate to increased risk of mental health issues in particular, and difficulty in future relationships, jobs, drug and alcohol dependency, and increased incidence of suicidality and of adult incarceration. So although we've mentioned that this isn't all down to parenting or any of those sorts of things, that ADHD is at its nature a genetic neurodevelopmental disorder, certainly there are some non-pharmacological strategies that you can put in place, that a family can put in place in order to support their child. These include routine, parenting and family-based strategies, attention to sleep, attention to nutrition, and involvement of other professionals. We'll just touch on those all briefly. A routine is really important, and you know, honestly, that's important for every family and every parent. Most of us respond better to predictable day-to-day routines, and it helps people who have executive dysfunction, and often that's kind of in the family, running through the family, to have a predictable day-to-day routine so that things are happening in the same way at the same time, and they understand what needs to be done in order to meet the requirements of the day, be that going to school or work. Limiting screen time is also really important, because screen time and the fixation that children can have with it can be really dysregulating, particularly for those children who struggle to transition from task to task. One of the best ways that we find to do this is to really crowd it out with other activities, either family-based activities, leisure activities such as going to the park, or more scheduled activities depending on what the family can manage. If this involves some physical activity or engagement in music, etc., something creative, even better, we can then see the benefits in terms of mental health, you know, metabolic and physical health, and then also onto sleep. I've mentioned that they may benefit from the help of an OT or a speech therapist with relation to this, and that's because some children can really benefit from visual schedules, both at home or at school, to help them develop a routine and a schedule to follow throughout the day. These are some just very simple examples, and they're widely available on the internet if you Google visual schedules, or even social stories, which are slightly different, but a similar sort of idea, particularly for children who haven't yet learned to read. These are really easy for parents to mock up, and it can be quite nice to put in pictures or even photos of the child themselves that they can resonate with. And they could develop the routine themselves so that, you know, it's relevant to the day of the week, what they have on that day, what they need to take to school, etc. Sometimes parents do find this very tricky to do themselves, particularly if they have their own executive dysfunction, and that's where I find that an allied health therapist like an OT or a speechy can be beneficial. So even if they can't access them on an ongoing fashion, a few sessions with one of those professionals can, you know, really be quite good at scaffolding the child and providing some strategies. Obviously, stability in a household is really helpful to a child, not always achievable, particularly if a child's family is going through a period of instability, with financial instability, insecure housing, parental separation, etc. But one of the things to really emphasize and try to get on board is that consistent boundaries are applicable across the household, and then across both households if the child does go to different households. Sorry, I'm just distracted because something's just appeared on my screen. Excuse me one second. All right. I'm sure you're all aware of the fact that, for example, Melton Health and other community health services will have social workers who can help provide other supports to families that are experiencing those difficulties, and Orange Door, particularly for families who are experiencing family violence. a particular parenting program that I love that's not been able to be so easily accessed of recent years, but is often run through Melton Council, for example, and through your local councils, is Circle of Security, which is a really trauma-informed parenting program. And that really helps parents develop their own abilities to co-regulate with their sometimes quite dysregulated children. Sleep, I won't harp on this too much because I'm sure you all know the importance of childhood sleep, and all the standard recommendations about sleep hygiene and minimising screen time in those in that hour before bed. Certainly, we're not averse to using a little bit of melatonin in children who have ADHD, as well as other forms of neurodivergent to help with some sleep onset. And I'm happy to answer any questions about that later if anyone has any questions. And also pointing them towards the Raising Children's Network, which is a wealth of resources for parents around sleep. A common question that parents will ask is about the various diets that have been discussed for the treatment of ADHD. Generally, we just recommend a healthy, balanced diet. The research is not supportive of elimination diets such as the GAPS diet or low salicylate diets or anything like that you may have heard of. And while there's often no harm, often children with ADHD can be quite picky already with their diet. And particularly if you then go on to stimulants and their appetite suppressed, it's really very hard to manage and can be quite an expensive thing to do. There is limited evidence supporting the use of fish oil in sort of milder symptoms of ADHD, but it's not something that we routinely recommended and can be quite unpleasant for some children if they're fish-based supplements with, a fishy aftertaste with the burping and minimal supportive evidence of benefit. Other health professionals that can help are certainly an occupational therapist, as I mentioned, to help with basically self-management in the classroom and at home, and can often visit into the classroom to help with environmental strategies, fidget toys, fidget cushions, visual scheduling, breaking down of instructions, all sorts of things to upskill the teacher as well as help the child perform better in that setting. A psychologist can certainly help with emotional self-regulation and also with complex family dynamics. And sometimes when behaviours are particularly challenging to manage, I do recommend that parents themselves see their own psychologists, as adult psychologists are actually easier to access than child psychologists at the moment, as you probably have all experienced. That can also be really beneficial for them to get a better understanding of themselves and how they parent. There is an emerging field of ADHD coaches for young people who are able to provide some lived strategies from their lived experience, but it's not something I'm super familiar with, and I think the body of evidence is still emerging in that area. And of course, there are a variety of written resources through the PHN information that Jo shared earlier, through the Royal Children's Hospital Network, Raising Children's, and some other resources that I'll mention later. So pharmacological management is actually pretty limited. We do have a number of medications that have come on the market. One medication really that's come on the market of recent times, Intuniv, which is a non-stimulant medication, which has been a very useful addition to the ADHD pharmacological management arsenal. But typically, most paediatricians start off with short-acting Ritalin, so short-acting methylphenidate, which we start at low doses, depends on the size of the child, but usually it's something like 5 milligrams twice daily, morning and lunchtime, to cover the school day, and to see the improvements in those settings. Once we've adjusted the dose, monitored for side effects and adverse reactions, we then switch to a longer acting form. And why we switch really depends on what the child's response has been, what time the child goes to bed, so therefore how long you want it to last for, and really what symptoms you're trying to target, whether it's just the school day or after the school day as well. Some adult psychiatrists, I've noticed, anecdotally, will just start straight with Vyvanse, which is lisdexamfetamine, which some paediatricians also do as well. But this really comes down to personal preference. And you can use some of the non-stimulant medications when you're concerned about things like appetite suppression or increased anxiety, or they're particularly quite young and you don't want to start a stimulant medication, or they have very significant tics, because some of the side effects of stimulants include things like worsening of tics and anxiety, as well as mood changes and emotional lability. For most children, if you keep the dose fairly low and you start it slowly and warn them about that, the families are really quite happy to deal with a little bit of initial emotional lability if it means that overall the behaviours of concern, such as difficulties with impulse control, inattention and concentration, improve. But there are certainly a cohort of children, adolescent boys, for example, where the mood changes can result in a lot of aggression. And that certainly can lead to needing to reduce the dose or stop it. If stimulants are taken too close to bedtime or a long-acting preparation hasn't yet worn off, there certainly can be issues with sleep initiation difficulties. And so sometimes you see people who get their medications mixed up and they take their Catapress in the morning and their Ritalin at night accidentally, and they'll be awake for hours overnight. And the appetite suppression can be really marked. So for children, we really need to watch that in terms of their growth. Sorry, that was it. So, so cardiovascular side effects. The majority of the time, there's no contraindication to starting Ritalin. Usually, if a child does have a previous cardiac condition, we discuss that with their cardiologist. It's rare circumstances where we can't start some form of stimulant. There will be a transient increase in both blood pressure and heart rate, which usually resolves once the medication is cleared from the system. So, but that is just something to note. There's some evidence that says that there may be some longer term effects from that, but that's not generally what's supported more widely. So monitoring involves really monitoring for the presence of side effects. So the big things are growth, and including height and weight. And we also like to take 6-monthly blood pressures just to make sure that's not deviating outside of the norm for that child. Presence of the side effects, as I've mentioned, to do with appetite suppression, tics, anxiety, etc. But also, importantly, is this working for this child? Are the target symptoms actually being addressed? And is it the right medication? Do we need to adjust the dose? Do we need to switch to a different long-acting preparation or a non-stimulant medication, for example? And I think that's really important to explain to families that this is not going to be the magic wand. It's not going to cure all of their child's problems. It's not going to stop them from, swearing or from being annoyed that they don't like something for dinner. It's not the cure-all, but if we are seeing an improvement in school behaviour, engagement, then that's great. So the role of the GP, you know, as we see it, is that you are the child and the family's main point of contact and care. You are their main doctor, their primary care provider. And so if you are concerned about the child, you know, as you would, start a discussion with the family about the next steps. Make referrals to the services as soon as you have concerns, because even in private, the waiting lists are really long, but in public, even longer. So, for example, it's 2 years approximately at the moment for a child to see a paediatrician in our service for a behaviour or developmental concern, which is terrible, but that's the reality at the moment. Including as much information as you have is absolutely fantastic, and that really helps us. So if the parents have brought you cognitive assessments or early intervention reports or school reports or anything like that, that's really useful information for us to have. Often we've got a very brief referral, and so the first appointments, the first couple of appointments are often information gathering. Screen for medical issues such as difficulties with hearing, picky nutrition, including bloods if indicated for iron studies, and all those things that you know well about, and address any sleep issues. Once a child's received a diagnosis of ADHD and the parents and family have elected to commence medication, what we'd be grateful for is if in between appointments, particularly as our lists continue to blow out, if you're able to accommodate monitoring their weight and blood pressure at sort of 6-monthly intervals, monitoring any other comorbidities such as other mental health presentations, and considering whether further treatment or referrals are required to support that. And just checking in generally on the family function, school attendance and engagement with therapies. One of the things that's kind of been a bit of an issue across across Australia, and particularly you might have seen in Western Australia, is the difficulties accessing private paediatricians and psychiatrists who will initiate stimulant medication and continue to provide repeat prescriptions. This is not something that we've done a lot of in our service. We haven't worked very closely with any GPs to continue prescribing in between appointments, but it's certainly a possibility. I'd be interested to hear feedback from any of you if you've managed to do this successfully and what that's looked like. And certainly it's an evolving area. So once much like in adults, once the diagnosis has been made, you can apply for a permit to treat a patient with stimulant medication. And it's, I think I've attached the link here, but I think it's the same link as it is for people over 18. You know, and we can continue to support that with yearly appointments and reviews. The feedback that I've had from some paediatrician colleagues who've worked alongside with GPs while they've taken periods of parental leave, etc., have been that it's worked very, very well as long as it's within the comfort and scope of practice of the GP colleague. And I think that's it from me. I'm going to hand back over to Jo, and then we'll have a bit of time for some questions and answers.
Thank you very much, Trupti and Mandy. That was a fantastic overview, and lots of great information there of what we can do and, you know, resources we can use. So there's a few questions that we have that have come in, and then I've eliminated another couple. So I think I'd said to the Mandy and Trupti the melatonin things. So can you give us a bit of advice on whether you're happy with GPs prescribing melatonin and how you go about it?
Absolutely. It's one of the sort of simplest things that we can initiate. Obviously, for I'm preaching to the choir, I'm sure, here to say that you do all the usual things, but with sleep hygiene, routine, bedtime routine, screen time, all of those sorts of things. But particularly in autistic children, we see a lot of, or children who you believe are likely to be autistic or with ADHD, sleep onset can be a real challenge. And so really from about 4 or 5 years old, like beyond the time when it's just sort of developmentally normal, no longer developmentally normal to have those difficulties with sleep onset, we'd support the use of melatonin. We typically prescribe short-acting melatonin, and so thus in Melbourne, that in Australia, that means you need to get it compounded. In the Western region, there are compounding pharmacies in Gisborne and in Deer Park, which are the ones that we access most frequently. It's not cheap, but a bottle lasts for quite a while, and we find that short-acting or rapid onset melatonin, rather than slow release like circadian or other preparations, are more effective and can cause a lot less grogginess, fewer nightmares, etc. And I personally start at really low doses, so 0.5 milligram or 1/4 milligram, and we do a 3 milligram per mil solution as the first prescription. Do you want to say anything else, Mandy?
The only thing to add is the Raising Children website, which I think is mentioned in the ADHD PHN health pathways, and also at the end of our slides. I think that's a really good resource for those conservative strategies that Trupti mentioned earlier.
Yeah, and look, the sleep physicians will definitely say that these the melatonin is best used in the short term to help develop those good sleep, those good circadian rhythms and that good sleep onset. But experience is that it can often take a really long time for children to develop those patterns. And many of our autistic families, children, need to take it long term.
Thanks. I think there's also a compounding pharmacy in Hoppers Crossing that's open all hours, I've discovered.
Right.
Got some stuff for my dog down there, so there you go.
Well, I answer the question, Jo, then also I can see about iHerb.
Yes, yep.
So what I say, and Mandy probably says, is to begin with, we much prefer people to take the compounded. So therefore, you know what you're getting, you know that it works or it doesn't work, because the issue with online pharmacies is that they are sold in the United States as supplements, not as drugs. And so therefore the amount of melatonin in a gummy, for example, is not as carefully controlled. Having said that, nearly everyone ends up buying it from iHerb or Biovera. It is so much cheaper, seems to be fine. So I don't endorse it, but I don't insist that they continue to fork out $60 for a bottle of melatonin. And the question asking, did I say 1/4 mil or milligram? I said 1/4 milligram. Children can be very responsive to very small doses. So when I say kids on 5 milligrams, I normally cut them down straight away because it's just unnecessary. Most of the time, I'll cut them down to 2.5 milligrams.
And I think parents are really quite responsive to wanting to use something. I think they get, by the time they've often come into the GP or the paediatrician, that they're at the end of their tether. And I think giving them some strategies around sleep is often really quite helpful. And, they're quite grateful if they can get some sleep. It's much easier to cope with what's going on. And Karen's also added that there's a compounding pharmacy in Seddon. So we've got a few options in the West, which is great. All right, okay. So I had a question on the stimulants and the non-stimulants. Do they use them together at all? Yeah.
Do you want me to answer that one, Mandy? Or?
It's fine. I'm happy to answer that one, Tripti. So with the stimulants, as Tripti mentioned, usually we often start off with a short-acting Ritalin just to see that there's a response. But sometimes we get to the maximum doses of those stimulants, and then we may need to add in an adjunct, which is your non-stimulant form, which is the options, and often that is usually Intuniv that we add as an adjunct. But however, in some cases, we do try all the stimulants, and these are met with side effects such as difficulty with weight gain, growth, or emotional and behavioral changes that are not tolerated. And so often in those situations, a non-stimulant only may be indicated. So we can use them together, but there are also times that we use one versus the other. Yeah.
Okay, thank you. So the routine thing would be to use the stimulants before you'd use the non-stimulants. Would that be?
Generally, because evidence supports that they're the ones with the highest evidence of being beneficial. Yeah, so we usually start off with the short-acting.
And also the short-acting Ritalin can be started and stopped. And so particularly for our families where you're worried that they're not going to remember to give the child medication every day, it's actually really great that you're not going to be worried about things like rebound hypertension or headaches or dizziness when you stop something like Intuniv, which can lower blood pressure and heart rate.
Okay, thank you. And you said that there was the adolescent boys sometimes have some issues when starting with aggressive behaviour. If they've already been on it from younger years, is that something that develops as they go along and become adolescents, or is it just seems to be at that age of starting?
Yeah, I don't know what you think, Mandy, but it's just definitely something that I've noticed more of. And then when you stop the stimulant medication, which you can do because you can start and stop it so easily, you do notice the edge of that being taken away a little bit. So I suspect it's kind of always caused agitation, but then circumstances, environmental, hormonal, etc., just really exacerbate that dysregulation. And it can be, if you do need to stop, it can be the difference between somebody who has been causing fistfights at school to, being able to tolerate school a bit better without being having as many aggressive outbursts. Just anecdotal, really.
Yeah, it's a tricky balancing act, isn't it?
I think it's a really complex question to answer as well, because as Tripti said, there are those comorbidities, and stimulants do bring out those comorbidities and make them a bit more prevalent. So once you treat the ADHD, you think things like anxiety present more often. And so as in young adolescent boys in particular, though, that anxiety can play out as getting aggressive when they do get anxious to regulate themselves and things like that. I think the other complicating factor is when the behavioral change, you see the behavior improvements on the medication. So when that medication wears off, the child can quite often become quite mentally exhausted and therefore have a lower tolerance. Also, difficult behaviors are more prominent because they're so used to the child being not impulsive and, well behaved, so that when this wears off, you've got this quite exhausted child and then with a lower tolerance. And so I think, but I don't think it's if they hit adolescence and this becomes prominent, I think it's a slow transition, and it's sort of can be noticed as time goes on, or it can be noticed right from the very start, and it's really hard to predict who will respond in one way. And this is why we start slow and go up gradually as well, monitoring really closely.
Thank you. And somebody's asked, is stimulant treatment long-term? How long? Are we looking at 10 years, 20 or 30 years? And when can it be stopped?
ADHD is a lifelong condition. So it really depends on the function of the person at any given point in time. So, we've seen more and more adults be diagnosed with ADHD in the past decade, and we've seen the life-changing benefits they've had from starting stimulant medication. And these are people who are high functioning, who run businesses, who've done PhDs, who are absolutely thriving, and they go and get their diagnosis, they start their medication, and, wow, what a difference to them. So it really depends on what's going on for that person. So you don't stop having ADHD. You may or may not at times in your life need the support of medication, for example, to help you. But a person who is working at home on their own, who's able to manage all their own time and structure things in a certain way, is going to have different functional needs to a stay-at-home parent versus a person who's chairing regular meetings and running a department. So, it's not a question of when can it be stopped. It's really more a question of when does it continue? When does the person need that support from a pharmacological solution? Maybe.
I think the other thing is there are a group of young teenagers that get to that age of 15 or 16. They've been treated for a long time, since early primary school, with stimulants, and then they go at 15, 16 that they do not want to take medication, and they feel like that they have the skills to sort of manage their condition without medication, and this is a decision that we allow them to make. Again, one of the benefits of stimulants is that you can stop it and it's out of the system fairly quickly, so it's okay for that. And these kids are usually those kids that have also had that combined psychological support, really teaching them those really good habits. So again, individual choice. And it's not one of those things that it's prescription, you have to be on it forever, or you have to, stop it after a certain time. Yeah.
We have some kids who just only will take it for exams and assessment periods where they really do need to focus. And you just have to monitor their usage of it to make sure that they're not peddling their medication to their friends for the same reason.
Fair enough, thanks. And another question is around the diagnosis or the age at diagnosis, and can this be made prior to the child starting kindergarten?
So generally, we do not make the diagnosis under school age. So the reason for that is a level of hyperactivity, inattention under school age children is quite normal. In the ideal world, we wait for the child to start school and have about a year in school. So really be supported by routine, really good habits, and that cognitive development that comes with age as well, before we make the diagnosis above 6. Saying that though, we, as discussed in the presentation, there is a strong family history. If there is a strong family history and there are features of hyperactivity and inattention that are causing significant functional issues, we may consider the diagnosis younger. But again, we're really cautious about this, and knowing that it may be cognitively different. So we monitor it and we consider non-stimulant options for this age group if appropriate.
I think the difference, you'll see these kids who are referred in when they're just started prep, and then you monitor them for a year, and that first year of school, the development is so immense. And so you see children who can't sit still on the mat, can't attend to any of their reading circles, etc. And by the end of the year, they've made really significant functional improvements. So, they have to be literally bouncing off the walls for me to really want to make that diagnosis much younger than that. But we certainly do, and we certainly all have children who are on stimulants from age 5. Not a lot of them, but we certainly would do that. And so, look, if you're a GP who sees a lot of people, a lot of kids with ADHD, and you're very convinced from age 4, we'll get that referral, and that's absolutely fine. We'll still see them.
Yeah, I guess perhaps if we've got the waiting list at the moment, they might be 6 by the time we get to them. Yeah, which is the difficulty. All right. One last question before we wind up. Is the dose of medication dependent on the weight of the child or adolescent?
Yes. Yes, it is. To an extent. So Ritalin, you go to a maximum of around 1 milligram per kilo, but some kids you go up higher than that to a maximum, a very definite maximum of about 2 milligrams per kilo. That's a lot, wouldn't you say, Mandy? And intuitive is also weight dependent, but I can't remember those numbers off the top of my head.
Great. All right, well, we might wrap up. I think that Yvonne's got a little slide with a QR code that she's going to put up on the screen for people to scan so they can give us their feedback and let us know your thoughts. So I'd like to thank Mandy and Trupti for a fantastic session tonight, giving us a bit of an update and things that we can start to do in general practice as we're working these kids up. If they do need the referral, we can provide as much information as possible and some of that collateral information in the referral, because it will then make it much easier to pull it all together when they are finally seen by the paediatrician. Wording the parents up that when they do get that appointment, if they can take some updated school reports and things, I think that's really quite helpful. So for those of you who've been asking, this session and all the resources will be available on the Northwest Melbourne PHN website, YouTube channel. And if anybody is interested in the session that was done last year on ASD, then that's also available on the website. So if you'd like to go through and have a refresher, I think we find with these sessions, there's a lot of information that we get in the short period of time. So great to go back and have a look at the session, look at some of the resources, and also look at health pathways. So as you know, when you do get a child come in with the family, that you've got some extra support there that you can start to work through. So thank you very much. Thanks to Yvonne behind the scenes. And Yvonne will get everybody out their certificates and their CPD points over the next few weeks. So don't panic, it will come. So thank you very much.
Thanks.
Thank you all.
Bye.
Bye.